Yeah, good afternoon, everyone. Yeah. From the very beginning, during our MCH, from the first year onwards, we keep hearing the words ASD and VSD. But this looks like a very basic topic. But however, unless you have a basic understanding of in detail, you will not have a better outcomes. And since the best way to resolve the problem would be to prevent it, and post-operatively, any VSD closure can have any of these complications like conduction issues, a residual VSD if you don't care about the margins, and the valve injury which is adjacent valve, and rarely, very rarely, a septal artery can be injured causing septal hematoma. And the approach to the VSD, initially the approach to the heart can be any of these, and this I am not going to discuss in detail because it's not the purview of the topic. And when you are dealing with the VSD, make sure whether you are dealing with a simple isolated VSD or it's a multiple VSD or it's associated with an AV canal defect or conotruncal anomalies like tetralogy, DORV, TGA, truncus or interrupted aortic arch, and whether it is really routable or not, and whether it is associated with overriding or straddling valves. And a VSD can be associated sometimes with a coarctation, and in such cases make sure whether you and have a proper roadmap to deal whether in a single stage or if you want to go ahead in 2 stages. And once you put the patient on OR table, just if you have a complementary intra-op TEE, make use of it to identify the VSDs and associated lesions. And we actually do an intra-op TEE so as to plan our approach. This is the RV inflow and outflow approach. This is the RV inflow, and any VSD which is closer to the RV inflow, we usually open RA to access the VSD. And this is the same RV inflow and outflow approach, and here the VSD is closer to the outflow, and this is the pulmonary valve here. And so in such cases, we actually directly try to open the PA to access directly the VSD. And you can also sometimes make use of opening aorta or the ventricle depending on the location of the VSD. And once you are okay, once you make use of the TEE and you have a proper roadmap, then go ahead and decide on the patch material before you give plegia. You can either use an autologous pericardium, either use an autologous pericardium which can be either treated or untreated, and the treated pericardium will give you a better handling of the pericardium. And if it's not available, you can again use a bovine pericardium or synthetic patch materials like Dacron or Gore-Tex in case if you are going for a redo to close the VSD. And even in redo, sometimes you can have an autologous pericardium like post-PA banding, you can even get autologous pericardium and treat it properly. And again, then regarding the size of the patch, make sure you take a proper size of the harvested patch material. Either it is a autologous pericardium or if you are taking a synthetic patch material. And if you are planning to close and augment the pulmonary artery, and take an oversized patch of the pericardium so that you can augment the pulmonary artery also. And once you go on bypass, before you go to a VSD closure, try to have a bloodless field, and if you have an LSVC, decide on whether to cannulate or not depending on the presence of bridging vein. And proper LV venting is must, and it is the site of LV venting depends on whether you want to cannulate, vent it through right upper pulmonary vein or an ASD or an LA appendage. If it's sometimes it is very difficult to cannulate the right upper pulmonary vein to vent the LA, and in such cases, just immediately after giving plegia, go ahead and open the RA to vent it, create an ASD and vent it through the ASD. And sometimes if you feel you will have, you can even use the LA appendage to vent the LA. And if there is already an associated ASD, you can make directly use of it to vent the LA. And once plegia is given, take time to assess the location of the VSD. And this I wanted to show you. For the exact location of the VSD, if it is a perimembranous, it can be again a perimembranous outlet VSD a perimembranous inlet VSD, inlet VSD and a perimembranous trabecular VSD. And if it is a muscular VSD, it can be a muscular inlet VSD, an apical muscular VSD, or a mid-muscular VSD, or an anterior muscular or infundibular muscular VSD. And the doubly committed or juxta-arterial VSD lies here, where it is very close to the annulus of both the aortic and pulmonary valves. And you can, again there is small confusion regarding the muscular inlet VSDs and the posterior muscular VSDs. See, the muscular inlet VSD lies just beneath the septal leaflet of the tricuspid valve, where the posterior muscular VSDs lies in the trabecular portion of the septum. And in both these cases, you have a common point that this conduction lies anterosuperiorly at this margin. And for the posterior muscular VSD, you have adequate margin, whereas for the muscular inlet VSDs, you have very small margin, and it should be very careful while closing the VSD. And then regarding the number of VSDs, you can have multiple VSD or a single VSDs. And if you have multiple VSDs, there can be two large VSDs. Like here, when there is a perimembranous VSD and an inlet VSD. In these cases, never cut down the tissue between the septal bridge between the two VSDs, because this is the conduction which goes in between these two VSDs. So either use a two patch separate closures, or you can even use a single patch for the closure of both the VSDs. And again, the multiple VSDs can be two muscular VSDs like an anterior muscular and a mid-muscular VSD, like anterior muscular and a mid-muscular VSDs, where you can close either with a two patch or a single patch. And regarding the size of the VSD, you can have a separate, small, moderate and large sized VSDs. Small and moderate sized VSDs almost always have a non-obstructive subaortic membrane, and take time to evaluate and excise the subaortic membrane, though it is non-obstructive, because the small sized and moderate sized VSDs, when they have subaortic membrane, they almost sometimes have some adherence to the one of the leaflets of the aortic cusp, which pull the aortic leaflet, and that can cause prolapse of the leaflets. And in order to have a normal leaflet movement even after surgery, it's always better excise the non-obstructive subaortic membrane. And once you excise the subaortic membrane, both the small and moderate VSDs, they look even bigger than it was before. And so the patch size of the patch should be taken only after the excising the subaortic membrane. And regarding the margins, you sometimes have more trabeculations on the margins of the VSD. Like in this picture, there are more trabeculations on the margins of the VSD, and this can happen with any of the VSDs like subaortic VSDs or inlet VSDs or muscular VSDs. So in such cases, if we suture the patch on the trabeculations rather than on the margins of the VSD, there can be intramural VSDs, multiple exit points, and it's very difficult to find out because the actual entry point is here and then the exit is here. So multiple exit, we keep trying to close here, but then this will not resolve the problem. So always try to close the patch, suturing onto the margins rather than onto the trabeculations. Here it is apical muscular VSD, where this also has some course through and having an intramuscular VSD as a complication after VSD closure. And if you have caudal attachments which are hindering the visualization of the VSD, then better consider detaching the leaflet of the septal leaflet of the tricuspid valve. In small and moderate VSDs, you can sometimes have RVOT muscle bundle hypertrophy as part of causalization, and always consider excising these muscle bundles. And in a malaligned VSDs also, excising the RVOT muscle bundle will push down the VSD, and it will allow us to easily suture the patch onto the VSD. And then the most important thing is the medial papillary muscle and triangle of Cox for the conduction axis, and it's very important to just check these two important things before considering the closure of VSD, because for the membranous VSD, the conduction is posterior inferiorly going, and for the muscular inlet VSDs, it's going anterosuperiorly. But for an outlet VSD, it is removed away, so you can consider closing it directly without any fear of damaging the conduction tissue. This is a normal heart. This is a normal heart wherein the triangle of, this is a triangle of Cox. This is the coronary sinus which forms the base of the triangle, whereas the septal leaflet of the triangle, septal leaflet of the tricuspid valve forms one margin of the triangle, and the commissure between the eustachian and Thebetian valve becomes prominent when and goes towards the central fibrous body, forming one of the margins. In the apex of the triangle, there is the AV node, and from there, this is the conduction which goes normally. And here is a cross section view, and when there is a VSD, this is a perimembranous VSD where the conduction lies posterior inferiorly, and for the inlet muscular VSDs, it is anterosuperiorly going. And this is in the other section for showing in relation with the perimembranous and the inlet muscular VSDs. But the other muscular VSDs are all far away from the conduction system. And this is in tetralogy. Tetralogies usually have conoventricular VSDs, and usually they are slightly far away from the conduction tissue as shown here. But sometimes there can be a perimembranous extension of the VSD and the conduction system is closer, and in such cases there can be heart block when you close the VSD very close to the conduction system. And this is the AV canal defect, and here the coronary, this is the coronary sinus, and this is the AV node, wherein the AV node is always pushed posteriorly. And here this is a non-branching and non-penetrating bundle, and this is the area where you should be careful while closing the defect. And in CCTGA, the most common variant is situs solitus with L-looped hearts, and in such cases this is the VSD and the conduction runs anterosuperiorly, whereas in situs inversus with the D-looped hearts of CCTGA, it runs normally in the posterior inferior direction. And in CCTGA with situs solitus and L-looped hearts, there can be an additional posterior node which can form a continuous link of conduction tissue. And this is a cross section of the same, showing the bundle and then bundle and the node, anterior node. In children with heterotaxy, when there is a D-looped heart with an left atrial isomerism, again the conduction is posterior inferior in most of the hearts, but then sometimes the bundle can be discontinuous and it can cause complete heart block. Whereas in L-looped hearts, irrespective of the isomerism type, whether it is left atrial or right atrial, dual AV nodes can be anticipated and they can form a continuous link of conduction around the VSDs. And predicting the location of conduction can be challenging, particularly in the absence of coronary sinus. In the absence of coronary sinus, which is an important landmark for defining the location of conduction. And these days, the role of electrophysiologic mapping and then recently FCM, the fluorescence confocal microscopy, has evolved more in identifying the location of the conduction for the complex congenital heart defects. This is the electrophysiologic mapping probe. This has multi-grid catheter, and this covers large areas, and it needs a heart which is beating to proceed for identification of conduction. Whereas for the FCM, this catheter tip is very small, and this can only cover smaller areas of endocardium and hence takes larger time to identify the regions. But however, this is more precise, and this is the appearance of a working myocardium which is striated in appearance as this emits a blue light using this tip. The working myocardium has a striated appearance, and the conduction tissue has irregular and reticulated appearance. So based on this FCM, the identification of conduction is very precise, but however it takes long time, and this needs arrested heart, whereas this procedure needs an beating heart. So each of them complements each other. Both of them complements each other, and this is how FCM maps the conduction area. This is the conduction area which is irregular and reticulated, and this is striated in appearance, which is a safe area for suturing. And based on the FCM studies, this is the conduction in the VSD, which is posterior inferior. For the AV canal defects, it is close to the coronary sinus, and for the tetralogy, it is in conoventricular VSD, it is slightly away. And based on and for the electrophysiologic mapping, this is how the tracing comes as it is in the beating heart. And I just wanted to discuss a rare complication which can happen after a VSD closure. This happened to one of my VSD babies which I operated 2 years back. and the VSD closure was absolutely normal. On partial bypass, after IVC clamping, we checked on TEE, that was okay. And once we came off, within a minute, we found there is something wrong. And on TEE, we found this. On TEE, we found this. And we were not sure, and this is one of the complications which I never had seen nor even heard of, but it happened to my patient. So after some time, just in a minute, we thought we will have to go back again, and then we took time. Just in a minute, then we realized that this is a septum which is splayed out, and there is a hematoma within the septum. And then within a minute, we were on bypass, and we had to decide on what to do. Then I gave plegia, I opened the septum, and from that side, I just, with a blunt dissection, I just released this hematoma on the other side, and on this RV side also I released it, but both are not on the same, exactly on the same side. And this I wanted to tell you because this can happen for any of our patients. This, in such cases, never do sharp dissection because this can even cause a iatrogenic dissection after repairing, so after healing. So always make sure you do only blunt dissection and give time for it to heal, and there will be LV dysfunction, septal dysfunction, and after 4th day we could extubate the child, and on 10th day we could discharge the child, and the child had some moderate LV dysfunction for 3 to 6 months. Slowly the child recovered and the child was doing well. But intra-op TE, I just want to tell you that intra-op TE is a very complementary thing, and in this case, had we not had a TE on table, we would not have saved the child because we were not aware of what is happening. Except that all of a sudden, after coming off, we could only observe that there is a sudden change on the epicardial coronaries, that there is contusion along the epicardial coronaries. Except for that, we did not have any other clue regarding this. So, and it is a timely intervention that saved the child because RVOT was completely occluded by the septum which was bulging. Actually, I could not get all the videos, but RVOT was completely occluded, and it was a timely saving procedure which we could do. And always be aware that anything can happen on table. And the suturing technique can be a continuous or interrupted, whichever you are comfortable, you can do it. And if you are not sure with the continuous technique, make sure that you take an additional interrupted suture using Proline. And this is a sandwich patch technique which we can apply when we have multiple VSDs. And here this is the patch which we take from the LV side onto the LV side through the mitral valve, and one more patch is taken on the RV side, and both of them then patch together. And this is a apical muscular VSD where you have to incise an apical infundibulotomy parallel to the LAD, and this is apical muscular VSD both below and above the moderator band, and you can suture it carefully with a single patch, just retracting the moderator band without excising. And this is what I wanted to tell you. This just for a knowledge sake, I wanted to tell you about the septal artery hematoma. Just because septal artery hematoma has occurred in that case, I wanted to focus on the septal artery anatomy also. And this article is from the Royal Brompton Campus, London. And this is a normal septal artery anatomy where the normal septal artery is found to arise from the superior interventricular artery, just as a when if you draw a perpendicular line from the diaphragmatic surface of the heart, it just meets the medial papillary line. This is the usual origin of the septal artery, but when we have an VSD, this is how it courses towards the medial papillary muscle, and this is the place where there is a chance of injury. And particularly the other thing why this is also important is when you enlarge the restrictive VSDs, this is the only safe area that you will have to enlarge, particularly in DORVs and DILV and tricuspid tissue. If you have to enlarge a VSD, this is a safer area, and never go beyond this area because you might have, and even then there might be some septal artery variations, but still this is the more safer area to enlarge the VSD. And small subpulmonic VSDs, they might have normal PSIs, but still you sometimes might have to operate because there is some RCC prolapse, some aortic cuspal prolapse. So in such cases, augment the main pulmonary artery with a patch, because the size of the PA might be normal at that time, but sometimes it can cause supravalvular stenosis later on. And non-obstructive subaortic membrane and RVO-TVO can be there with small and moderate VSDs. Still, though they are non-obstructive, try considering resecting the RVO-TVO and excising the subaortic membrane, because this subaortic membrane, once you excise, the aortic valve cusp will try to become normal. And always check the valve leaflets after closing the VSD. Once you close the VSD, try to check the tricuspid valve leaflets or the pulmonary valve leaflets if it is subpulmonic VSD. And sometimes there can be unreported issues like MR, and you will be surprised on table once after closing the VSD you might find an MR, and decide on whether you really have to go and intervene or not. Make use of TEE in such cases. And check for if the symptoms are disproportionate to the size of the VSD. As soon as you see in the OPD, please check for the peripheral pulses for associated coarctation. And in the presence of severe PAH with VSD, Al-Kappa can sometimes be missed, and watch on it. And the prolapsing leaflets is an indication for VSD closure for the very small, even for very small VSDs. And never think that since the VSD is very small, there is no indication for surgery. Prolapsing leaflets, even though there is no regurgitation, is an indication for VSD closure. Thank you. Thanks for your patience hearing.